Good evening. Welcome to the San Mateo, Mid-Peninsula, San Francisco, Southern Alameda, Monterey Bay, and Harbor Dental Society's webinar. We have a great audience joining us. My name is Dr. Tyler Davis. I'm the president of the San Mateo County Dental Society. Before we get started, I want to review how we will be running the meeting. All participants will be placed on mute. Tonight's presenters will provide information about the responsibilities and requirements for prescribing controlled substances, Schedule II opioid drugs. This course satisfies the 2 CE unit requirement made effective by the Dental Board of California for license renewal. During the presentation, you may post a question into the Q&A box. For those participants on your desktop, the Q&A box is located at the bottom of your screen. For those on an iPad or iPhone, the Q&A box should be on the upper right. Please feel free to post your questions, and if time permits, we will go over them at the end. Tonight's presenters are Dr. Casey Grover and Rob Close, both MDs. Casey Grover, MD, is an emergency physician at Community Hospital of the Monterey Peninsula and the physician champion for the Monterey Community or County Prescribe Safe initiative. He attended medical school at UCLA and completed a residency in emergency medicine at Stanford. In addition to his practice in the emergency department, he also practices addiction medicine and is chief of staff at Community Hospital of the Monterey Peninsula. Reb Close, MD, is an emergency physician at Community Hospital of the Monterey Peninsula and the lead clinical physician for the Monterey County Prescribe Safe initiative. She attended medical school at UCLA and completed a residency in emergency medicine at UCLA. In addition to her practice in the emergency department, she also practices addiction medicine. Welcome, Dr. Grover and Dr. Close.
Good morning or evening or whatever time of day it is.
Has it really been that long of a
It has
day?
been that long of a day. So since both names are androgynous, I'm Reb Close and that's Casey Grover. And thank you so much for hosting us and for having us and really for being open to this discussion and communication about what we see practicing addiction medicine and how we can partner to make things better for our communities. That's really what this all boils down to from our standpoint. So
we're married.
That
So, gosh, it has been 18 and a half years.
something. Yeah.
You didn't know what time of day it was. Do you remember how many years we've been married?
You're right.
I'll give you a hint. It's 18 and a half.
Thank you.
Yeah.
Yeah.
So, yes, welcome to our living room. Our dog's sitting right there. Our kid's about to go to Taekwondo. And if you've heard us speak before, my condolences. But apparently there's not a lot of folks lecturing in this space. So we both came to addiction medicine a little bit in a circuitous route. We both trained as emergency medicine physicians. We have taken care of all manner of dental emergencies at 2 a.m. And
Probably poorly.
Yeah.
I need to tell you, ER docs, we do our best, but yeah, we know
what is
we
it?
don't know.
The tooth? Is that the important part?
Stop.
Okay. Sorry. Focus. Okay. So yes. So anyways, yeah, we really realized that something was wrong with everyone getting opioids. Maybe 2012, 2013, maybe even before.
Yeah, go back.
What are you trying to say?
It was a while.
Okay, fine. She says it was longer. We've been doing this for about 15 years. And we actually need to update our bios because we no longer both practice in the emergency department. And we focus on addiction medicine. So I was with my patients today. They use fentanyl, cannabis, ketamine, whatever. And we do have some expertise in pain management. I was the chair of the hospital's pain management committee for, I think, 8 years. We helped our little hospital in Monterey get nationally recognized for alternatives to opioid practices and opiate sparing practices. So we've been in this space for quite a while.
I think the other important thing is I use a lot of information and experience that I receive from my patients. And so as Casey mentioned, we don't work in the ER anymore. We've gone full-time addiction medicine. And so I have some information from the ER and how things started and how that plays into this. But I think the most important thing is where my perspective comes from now. And so we both work at kind of a brick and mortar addiction medicine clinic. As you can see, the logo on the right, Pacific Rehabilitation and Pain. One of our pain specialists here in Monterey had the amazing foresight to realize that there's a lot of crossover between chronic pain and addiction. And so he brought us into his practice and was very open doors, like, you guys do what you need to do, and thank you for taking good care of people. It was awesome. And so that's one of the settings we work at, is a brick and mortar pain clinic affiliated addiction practice, which is amazing. But the other things that we do are incredible. And I spend a lot of my time doing street medicine in the encampments. Gosh, digging around in Chinatown, which is our version of Skid Row, and really trying to connect people to treatment there. And I will say, one of my gentlemen, we take care of a lot of people that have horrible, horrible, horrible dental disease associated with years of neglect and substance use,
And
and
meth.
you all understand this.
And more meth.
Yeah, the meth has never
The meth doesn't help.
meth doesn't help
It
anything.
never helps, actually.
But I saw one of my gentlemen yesterday who has been really struggling, the typical talk like this because you're embarrassed by your teeth. And I saw him yesterday with his dentures. He's had a full extraction, and all of his dentures are in while he waits to qualify to get implants. And I literally cried to see the transformation for this man. So I'm going to let you know that when I express my gratitude, it is on behalf of some of our most marginalized and some of the people in our society that really have most people look away from. Casey and I tend to embrace them. And there's a kid going to Taekwondo. Bye. Bye, darling. And so I just want to say thank you. I work in our jail connecting people to treatment. Again, I go on the street. And I see the people that society has really tried to turn away from, and I want to thank you for helping us bring them back into a world with open arms. So just a little plug for thank you.
So, regrettably, there are some requirements for this course besides just listening to the two of us banter and my wife steal stuff off my desk that I told her not to touch. I saw you do that.
I know.
Okay, so this is a mandatory 2-unit course for dentist license renewal. Very grateful that the government and state medical boards have started to say we need to incorporate addiction treatment and training into what we do. So Rev and I both went to medical school at UCLA. We trained at Stanford and UCLA, 15 years of medical education. We got an entire hour of training on addiction in 15 years. We were always taught, like, this is how you treat cirrhosis from alcohol.
Yeah.
But they never taught us how to fix the alcohol. And I was taught as a medical student, here's how you treat pain: acetaminophen, ibuprofen, and then escalating doses of opioids with no ceiling. How do we stop that? And they didn't teach us that. So thank goodness things are starting to really come full circle on being a little bit more reasonable with what people should be taught in terms of professionals. So we'll talk about responsibilities and requirements for prescribing, the prescription drug monitoring, what is it? Prescription Drug Monitoring Program, PDMP. We'll talk about techniques for pain management. Some of them are not involving opioids. Some of them are opiate sparing. We'll talk about when opioids are needed. We deal all day, every day with opioid use disorder. In fact, my last patient about an hour ago had opioid use disorder. We'll talk about some difficult scenarios, kids, people with addiction who have pain when they have a procedure. We'll talk about some of the educational kind of frameworks we use, kind of easy taglines you can use when talking to a client. And then again, best practices for pain management. Now, the history behind this, thank you, Monterey Bay Dental Society, is many years ago, we were approached by the Monterey Bay Dental Society and said, hey, could you guys talk about opioids? And this was, I think, 2017 or 2018.
Wow.
And we said, sure. So we put together some information, and apparently we didn't do a horrible job. So we got invited back post-pandemic, and this lecture has evolved over the last 4 years as we've updated it and learned and grown, and we've updated the data. So these are our objectives that will add to the requirement that the state licensing board requires. But We want to talk about why. Like, why was all of a sudden every American on opioids? And why is fentanyl the dominant drug in the supply? And why are we not worried about isotretinoin, which is an opioid no one's ever heard of? We'll talk about what's worked for us in Monterey County in terms of being smart about trying to reducing exposure of new patients to opioids. And we'll share some of the things we've come up with over the years about how to kind of easily educate people about some complicated things. And then a lot of the things that we do around safe pain management that reduce the risk of addiction, dependence, which we'll talk about, and overdose. What did I miss?
No, I think you're doing great.
You think I'm doing great? Okay.
Strong work.
Is it just we're married 18 years since said that?
You got this. You got this. Come on, move on.
Oh my gosh. Okay, here we go. How on earth did we get to where opioids were such a big problem? Well, I love history and I love reading, and even better, I like exercising, listening to an audiobook. So you'll see some of the book titles that share some of the story in a much greater detail if you want to take a read or a listen. So this is really the first book that came out that said what's going on with opioids in America. The author is Sam Quinones, who's fantastic. Excuse me, he's written a sequel actually, but this came out in 2013, and this was right around the time when we were going, like, what is happening? So, I don't want to ruin the book, but here's the cliff notes. So, traditionally, we did not prescribe opioids to patients with chronic pain. We learned, as we'll learn, hi dog, the dog came to say hi. We learned from previous experiences with opioids in America, which we'll talk about, that opioids were very addictive. And so we really did not prescribe opioids. And then we started to see some emphasis in healthcare providers that chronic pain is a real issue, whether it be back pain, TMJ, whatever it is, chronic pain needs to be addressed. And so many of our addiction patients have chronic pain. It just weighs on the psyche to always be in pain. So what did we sign up to do as healthcare providers? We wanted to help people. So we thought, well, gosh, maybe we can do a better job of treating pain. So we started to get some education coming out in the 80s and 90s that, gosh, maybe we should be prescribing more opioids. Maybe they weren't as addictive as we thought. Initial efforts were really comprehensive. I often refer to it as pain camp. It was like residential pain care. You saw a psychologist, a psychiatrist, a physical therapist, a nutritionist, a medical doc. Like, it was really wraparound comprehensive, but it was expensive. And we started hearing that opioids really weren't addictive. Maybe we were wrong this whole time. And all of a sudden, the floodgates opened, and pain was now a vital sign equal to pulse oximetry, heart rate, blood pressure. We really wanted to treat pain aggressively. We were being measured as medical doctors, like how soon were we giving morphine after a serious injury? Except turns out opioids were addictive. And we basically flooded the market with prescription pills, and then complex geopolitical interactions. We started to see the rise of the multinational criminal organizations, often previously referred to as drug cartels, really rise in power. And all of a sudden, heroin flowed in to take advantage of where opioids had been overprescribed. So let's go through it in a little bit more detail. This is, I think, my favorite. Well, this is actually my second favorite slide of this presentation. This is an original ad from the makers of OxyContin, and that was Purdue Pharma. What face did you just make?
That's my annoyed face. Go ahead. You should know it. For crying out loud, indeed.
So, Purdue Pharma used to be a company no one had heard of, but thank you, Purdue Pharma, because they ruined so many lives with the blockbuster drug OxyContin. Now, the Purdue Pharma and the company, excuse me, and the family that ran it, called the Sackler family, are much more in the public eye. Here in Monterey County, we actually have some funding coming in from all the lawsuits that have been filed against these drug companies. I just interviewed a guy in the East Coast who's working in Kentucky, and they're trying to use these lawsuits against these big companies like Purdue Pharma to try to make good on some of the bad things that had happened by increasing services. But long story short, no one knew at this time that Purdue Pharma was going to turn out to be a bit of a villain in this story. And this is an advertisement from Purdue Pharma about OxyContin. This looks great. Your doctor might prescribe an opioid medication. Less than 1% of patients become addicted. That's fantastic. Except it's
A lie. You can say it. It's totally untrue.
Maybe we'll say it's a distortion of the truth, as we're about to say. Okay, fine. It's like you've attended this presentation before.
No, I just get so irritated still, all these years later.
Those are my slides. Do you want to get my slides?
No, you can do it.
Fine.
It's fine.
Okay, I plan to bother you with your slides. Okay, sorry about the marital conflict here. Okay, so this is where that statistic comes from. Again, opioids, less than 1% of patients become addicted. This is where it came from. The New England Journal of Medicine, a very reputable journal. Addiction rare in patients treated with narcotics. This, in drug addiction geek circles like ours, is referred to as the Porter and Jick article based on the authors. And you saw we have a high school student in our home. Last year, as a freshman in high school, she had to do what was called a capstone project, where she had to research a topic and present it. And interestingly, her capstone project was more scientifically robust in its methodology than this article. You are looking at the entire universe's literature that supports that claim by Purdue Pharma. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 lines. It's a letter to the editor, and it basically said, we had some patients with cancer. They were in the hospital. We gave them opioids. Not that many got addicted. That is not, go give everyone with chronic back pain opioids. This is a very specific subset of patients. And it was more just like a, hey, by the way, rather than an actual scientific study. Unfortunately, this is really what got the research on opioids not being addictive that was pushed out by Purdue Pharma at the time started. And unfortunately, you can see how long we've been giving this sort of talk. I need to update this number, but this article was literally cited over 1,000 times over the years, perpetuating this myth that opioids were not addictive. The actual answer is, if you give any human being on planet Earth opioids multiple times a day for more than about 10 to 14 days, 100% of them will become dependent. That is not addiction. Addiction is the psychological phenomenon of drug craving, compulsive use, and using despite consequences. Dependence is when a person is on a substance. When they stop, they feel sick. In terms of the actual rates of opioid addiction, it's maybe somewhere between about 5 to 20% of people that are exposed to opioids will get addicted, and we can talk about some of the biology. But this was just misinformation that at the time we didn't know. What happened? We as healthcare providers said, you know what, if they're not addictive, let's go forth and prescribe. Let's help people with chronic pain. This is another great book, American Pain. This is about two brothers whose pictures you see on the screen. Both had previous criminal records, having committed felonies, and they saw a market. They said, you know what? These opiate pain pills are addictive. I bet if we open a for-profit pain clinic, we could make a lot of money. So what did they do? Florida, it turns out, has fairly lax regulations across the board. So they went to Broward County, Florida, and they opened a pain clinic, and it was called American Pain. They staffed the clinic with doctors who couldn't get a job elsewhere due to disciplinary issues. They put an MRI trailer in the parking lot, and anyone who wanted to come in and get opioids, they'd take for an MRI of the neck and back, and any disc bulge would go to the doctors to be prescribed large amounts of oxycodone, benzodiazepines, and sometimes carisoprodol, also known as Soma. They did not have nurses or medical assistants. They had strippers, true story, in scrubs, and they were making so much money that they had to have trash bins under the front desk to stuff all the cash. Back in I think it was the 90s, they were making $14 million a year.
Pause for effect. Yeah.
Did you really just pause for effect me? She just paused for effect me. Really?
That's good.
She just paused for effect me. These are not your slides.
Day. Go ahead.
Okay, sorry. Close is apparently losing it. Okay.
That was good.
Can't believe you
No, it
paused.
was awesome.
Anyways, the book is about how this happened, the consequences, and I think it's I-75 up and down the East Coast was nicknamed the Oxy Express because people from Appalachia were constantly driving up and down to Florida to get their meds. They were ultimately taken down by federal law enforcement, and these two guys are both disciplined. But at one point, it was so bad because of clinics like this in Florida that Florida was dispensing 9 times more oxycodone than the rest of America combined. You didn't pause for effect.
No, I was listening.
Pause for effect, please. Does anyone else want to present with her? I'm struggling tonight. Okay.
You're doing great.
Onward. Just as a sense of how Normal it became to buy and sell these prescription drugs on the street. You got websites like streetrx.com, which is still alive. You could literally go online and price check your prescription pills that you were getting from somebody who had it prescribed to them. These are some older prices, but $75 for a Tylenol 3 is not a good price. Lorazepam, $5 a pill. No, no, not so bad. Generic Vicodin, that's off the market now, $5 a pill. Yeah, it's an okay price. Clonazepam for $1 a pill in Florida sounds like a pretty good price. It just became so normalized to buy and sell prescription drugs on the street. So people talk about an opiate crisis. It's more like it comes in waves. And the first wave was the overprescribing of prescription medications. Now, wave two, we're going to talk about wave two in just a second, but let me explain the why behind wave two. Now, we just talked about dependence, right? Dependence is the idea, whether it's alcohol, cannabis, cocaine, opioids, benzos, whatever. When you use them regularly, your brain chemistry changes, and when you stop, you're in withdrawal. And according to the American Society of Addiction Medicine, this is their slide, this is the natural history of using opioids. Initially, you feel better. You may feel euphoria if you have opioid addiction. It helps with pain. Some of our patients experience a lift in energy when they use opioids. Genetically, some people release more amounts of pleasure hormones like dopamine and endorphins when they use an opioid, others do not. Some of our patients are like, oh my gosh, when I do fentanyl, I clean my house. Mm-hmm. Other patients will find that opioids make them dysphoric and nauseated and tired. So there's a subset of people genetically who are predisposed to opioid use disorder. So if any of your patients are like, doc, man, those Norcos, man, they really get me going, like that's a major red flag. We'll talk about that. But what happens is a person starts using opioids and initially they get pain relief and euphoria. Over time, they develop dependence, and because of tolerance, which is the idea that you have to use more over time to get the same effect, eventually they keep using more opioid and they're not getting the same level of pain relief and they're not getting that same level of euphoria. And so now they're just getting a little bit. So they're trying to use more, their receptors are getting saturated, and then they start trying to stop when it's not helping and they go into horrible withdrawal. And then as you see, as the slide progresses to the right, they get to the point where they haven't been high in years and they're just trying to stay out of withdrawal.
If you think about the homeostasis of our bodies, right? We like things as they are. And so if you're adding in these exogenous opioids, right, it changes the way the body chemistry is. And our brains are set up to say, okay, well, here are all these exogenous opioids. I don't need to produce any, natural endorphins or natural opioids. I need to bring things down. I need to change the receptors. I need to auto-regulate to get back to homeostasis. And unfortunately, as Casey was saying, that is where we get the physical dependence and the tolerance. And then if those opiates are removed, you're in this negative state. And that is your dependence. And as he very clearly said, I have patients that have not been high in years. I mean, they just use to feel normal.
They call it staying well. Like, doc, I was so sick, I had to get well. I had to use some fentanyl. I'm like, oh, I get it.
That's it.
We'll talk about the treatment of opioid use disorder in a little bit. Now, we as healthcare providers are responsible for what we prescribe. So if I prescribe my patient, let's say Prozac, because they've got depression and they get side effects, I'm going to discontinue that medication and try something different. So we as healthcare providers prescribe loads and loads and loads of opioids. And when our patients got addicted, what did we say? We're going to stop it because you're addicted. We missed withdrawal. I can't even count the number of times that people come into the ER and they're like, I need more Norco. I need more Norco. I'm like, you have an addiction. We're cutting you off. What happened? They went into horrible withdrawal. I didn't know any better. I really didn't. And I just think about, and I think back the number of times I wish I had understood this. I could have been like, hey, let's get you on Suboxone. Let's get you to a methadone clinic. Again, we'll talk about that later. But what was the one opioid people could get to stay out of withdrawal? Heroin. So I grew up in Monterey. If anyone up in the Bay Area has been down to Monterey, it's a quaint little area. There wasn't a lot of heroin, right? I thought of heroin as like an LA problem or Chicago problem or San Francisco problem. But we started to see heroin infiltrating all over America because people had been on their prescription opioids. They got cut off. and they were horribly sick. We met one young man who broke ribs. He broke a number of ribs bullfighting because we have a rodeo down here in Monterey County. And no, it's not a rodeo in Monterey County, it's a rodeo. That's another story. You just tell me to not say that?
No, I was just like, he's totally right. It is
I thought you were
not
telling
a
me to
rodeo.
cut it off. They don't
Or
need to
it's
know.
not a rodeo. It's not.
No, and it's the Salinas Rodeo. Anyways, bull rider breaks ribs. I don't know why they gave him 6 weeks of oxycodone for broken
That's
ribs.
what we did. We were horrible.
Well, and so he stopped after the 6 weeks. The doctor said, "You're healed." He went into horrible opiate withdrawal. He went back to the doctor. They called him an addict and cut him off. And so he used heroin for 6 years until someone could get him on Suboxone.
Yeah.
So now, heroin has a backstory. It turns out that in the Civil War, we had morphine as one of the very few medications that was available to treat soldiers' injuries. And it turns out so many soldiers came out of the Civil War in the 1800s dependent or addicted to morphine that opioid addiction and dependence was actually often called soldier's disease. And so people were trying to find a cure. How can we treat this? One person suffering from addiction to opioids thought, well, if opioids are addictive, I just need something else that's more addictive to get me off of it. So he combined cocaine, sugar, caffeine, and alcohol to make the original Coca-Cola. That was actually why it was created, to try to get people off opioids. It turns out he didn't work and his opiate addiction continued and he lost the company. But hey, it was a valid effort. Then Bayer Pharmaceuticals, yes, that Bayer synthesized a miracle non-addictive opioid called diacetylmorphine. And the brand name was heroin. Take a look. From the makers of aspirin, introducing heroin for the non-addictive relief of cough since 1898, also recommended as a safe and non-addicting cure for morphine addiction. Why did we not want to prescribe loads of opioids in the middle of the 1900s? Because we'd done this 60 years ago. As Mark Twain once said, history doesn't repeat itself, but it rhymes. In the late 1800s, we had a miracle non-addictive opioid called diacetylmorphine that, oops, it was addictive. And then literally 100 years later, Purdue Pharma did it with OxyContin. So that brings us to wave 2, which is heroin. Now, I always think it's funny that people think that drug dealers think differently than average people in business. Like, drug dealing's about money. You want to maximize your profits and minimize your costs, right? What does Toyota want to do? They want to maximize their profits and minimize their costs. Turns out, if you're in this industry, heroin's a lot of work, right? It's a plant. The heroin comes from the opium poppy. If you've ever heard the term opioid and opiate and not known the difference, an opiate comes from the opium poppy: codeine, morphine, heroin, and opium. Everything else that activates the opiate receptor is an opioid, like fentanyl or oxycodone. So this is a picture of an opium poppy farmer somewhere in Latin America. What do you notice? You need land, you need sunshine, you need labor, you need water, and you need those pesky cops not to come and cut down or burn your crops. So that brings us to wave 3. We've gotten America addicted on opioids with prescriptions. We've perpetuated the addiction with heroin. But you know what? We're in that drug dealing industry. We can probably really streamline our profits if we go to synthetic opioids. And that is wave 3, which is the arrival of synthetic opioids like fentanyl. Now, for us as ER doctors, fentanyl is great, right? Doesn't have as much hypotension as morphine. It doesn't cause itching and a rash to the same extent as morphine. And it only lasts 2 hours. So somebody comes in, they've got horrible abdominal pain. We don't know if it's ruptured appendicitis or a bowel obstruction or a really bad case of the stomach flu. So they're uncomfortable. We give them 50 micrograms of fentanyl, run labs and a CT scan and a urine test. And by the time their tests come back, the fentanyl's worn off. And if it's stomach flu, we can hydrate them and send them home. And if it's ruptured appendicitis, we're calling the surgeon. It's a very useful medication. It was actually synthesized in the 60s for analgesia around surgery. But why fentanyl in the drug supply? Well, it turns out in our geeky world of addiction, there's something called the iron law of prohibition, which is that if you make something illegal, people will still use it. They'll just find more concentrated ways to smuggle it. The classic example is the prohibition of alcohol in America. We used to drink beer and wine. We made alcohol illegal. We were still going to drink. So we switched to moonshine and whiskey because it was just if you were going to smuggle a barrel, you were going to take that risk, you might as well get more bang for your buck and be able to make more money. So why fentanyl? Turns out that fentanyl's fairly potent. So if you take a regular sugar packet and you pour out the sugar and you fill it with fentanyl, that's 4 grams. That is enough for a drug dealer to sell 40,000 doses on the street. When I go to schools and I give them education, I literally pull one of the teachers. I'll be like, Mr. Smith, we're going to quit our jobs and we're going to be drug dealers. I want you to hide this sugar packet. We can deal to 40,000 people. It's fairly easy to hide. If I give them a shoebox, they can't hide it. It's just too big. So if you are in the illicit drug market, fentanyl is a dream come true. You don't have to grow it. You don't have to process it. You just order it from a pharmaceutical company, and then it's so much easier to smuggle. You just maximize your costs, you maximize your profit and cut your costs. Now, if you're wondering, that same amount of fentanyl, 4 grams, is enough to kill 2,000 people. Do you want to pause for effect?
Price of doing business.
You didn't pause for
Oh,
effect.
I paused. I completely paused.
Okay. Unfortunately, it gets worse. So I don't know how all you all feel about cryptocurrency. I'm still trying to figure out how they basically kind of made money out of thin air, but that's a whole nother discussion. But drug dealing used to be done in person. You had to go call your dealer, meet them on the street, the secret handshake, give them the money. It turns out that people started to realize that the internet was working great for selling stuff like eBay. I wonder if we could make an eBay for drugs. Another great book, American Kingpin, was about a physics student named Ross Ulbricht who coded himself a eBay for drugs on the dark web called the Silk Road. And this is an original screenshot. You can buy whatever you want. And the good news is you can pay anonymously with Bitcoin or whatever coin you want at this point. But there was a major pivot as the internet became much more pervasive in our lives that drug dealing started to shift online. But that was peer-to-peer drug dealing. It turns out it's actually a lot easier than that. There are legitimate pharmaceutical companies in other countries that will sell you direct-to-consumer substances. So this is a company selling fentanyl. It's a pharmaceutical company in Asia, and basically you can just go online and buy fentanyl. And if you look at the bottom of the screen, it's sold as a research chemical. And I love the fact, but it like hurts my soul how much I love the fact that you can add fentanyl to your wish list. Go ahead.
Go ahead. This is why we're here. Actually, go ahead. I'm ready.
Did you need like emotional moment to eventually call the dog?
Maybe.
Yeah.
I mean,
Oh no, we lost the dog. I was gonna say if you need some emotional support, I can call the dog.
Seriously.
So it turns out that it continues to get worse. Turns out that fentanyl, because it's made in a lab, is very easy to modify in a lab, and so you can add side groups. So this, for size, these are vials that are 2 inches tall, about the size of your thumb. On the left is the amount of heroin that would kill me as a full-size adult. In the middle, the amount of fentanyl that would kill an adult. But it turns out that legitimate medical researchers were experimenting with side groups on fentanyl, and they were able to make more potent versions of fentanyl, like carfentanil, which you can see the amount that would kill me is a single grain. It is used in veterinary medicine to tranquilize rhinoceri, and elephants.
I think elephants, yeah.
You're the zoology major.
Oh, God.
Okay, sorry. Inside joke in the family. Yes, large mammals. They use this to tranquilize large mammals. Except it gets worse. Anyone remember that episode of Oprah all those years ago when she was like, you get a car, you get a car, you get a car, and she bought everyone in the audience a car? That's what's happening with our patients now with what are called fentanyl analogs, meaning you add a side group. It's not been studied before, but shoot, you add a butyryl group to fentanyl, and now it's butyryl fentanyl. You add an acryl group, and now it's acryl fentanyl. You add a methoxyacetyl fentanyl side group, and now it's methoxyacetyl fentanyl. We are now seeing routinely these chemical analogs of fentanyl showing up in our drug supply. Most of our patients in the last year have been exposed to at least one if they're actually buying fentanyl. And because fentanyl's so easy to smuggle, the dealers are lacing it into everything. I mean, you can sell, whatever drug, but if you lace in some fentanyl and it feels stronger, you can sell it for more. So our patients have no idea what they are getting. And sometimes they come in and they're like, Dr. Grover, can you please test me? I have no idea what's in my drug supply.
And very fortunately, we work with a lab that actually allows us to do this specific testing. Many people will go into the emergency room and they'll be like, oh, they tested me. Well, that's a very different test. It's more of a screening test, positive, negative type of a thing, and very indistinct on some of the different substances that are able to be tested. Fortunately, we do have a lab that will tell us, is this paracetylfentanyl, perfluorofentanyl, acrylfentanyl, whichever, I call it picafentanyl, because my patients, they want to know, and I want to be able to tell them, and as Casey said, they'll say, this, my dope is not hitting right. Something's wrong. And they'll come in and we can, as much as we're able to test at this point, I tell them, this is only what I know. All the stuff I don't know, I can't say, but at least we have some idea of what you're being exposed to. I mean, they really want to, they don't want to be in the position that they're in, that they're so sick and having such a hard time feeling normal that they're willing to use these substances in order to try to feel better and to feel well.
I
It's
mean,
really a hard road to be on.
there's also some patients that are fairly naive. I have a 65-year-old that was using fentanyl, and I got her stabilized on buprenorphine, but she continued to use methamphetamine, and we do her drug tests, and she started popping up for fentanyl again. And I was like, "Are you using fentanyl?" She was like, "No, I'm just using meth."
Yeah.
And I said, I have bad news. Your drug dealer's lacing in fentanyl to your methamphetamine. And she looked at me, she goes, 65-year-old lady, Dr. Grover, my drug dealer is so unreliable. And I was just like, oh my gosh, we got to talk through this.
It's
Okay.
true. Yeah, we have it all the time. My patients that are using, they believe they're using heroin, they believe they're using meth, obviously the cocaine, and they're unfortunately being exposed to fentanyl. So it's cheap, it's easy.
Yeah, unfortunately, it continues to get worse. As you can see on the screen now, you can actually also buy these through social media. So what we're seeing locally in our community is it's kind of a mixed bag. Some people go to the pharmaceutical companies in other countries. They bring it. They either make it to sell to other people to fund their own habit. There are some horrible adults that basically create large social media groups and kind of prey on high school kids. You need any cannabis, you need any THC, you need any nicotine. But it's kind of like people always ask, like, where are the drugs coming in? The answer is everywhere.
Yeah.
For any parents in this audience, this was a really profound quote that we were involved in a social media safety project. When you give your kid a phone or when you give your kid a computer, you feel like as a parent, you're giving your child access to the internet. It is not that way. When you give your child a phone or a computer with an internet connection, you give the internet access to your child.
Yeah.
And so we've really worked with our child on internet safety and just realizing that, like, our daughter's school actually sends out the Snapchat handles of these adults preying on kids. It is a really frustrating situation. So here we are. It's really the worst case scenario in terms of treating addiction. We overprescribed opioids. We didn't know how to treat it. And because we flooded the market, and thanks to the internet, social media, Bitcoin, the rise of all these fentanyl analogs, it's the wild, wild west in terms of what we do in terms of treating addiction.
So if we are super passionate about it and we're coming across as kind of these zealots about what can we do and how did we get here and how can we make it better, this is why. We're in the worst case scenario.
No, and
Something
it's
about
a
it.
horrible disease. I mean, addiction is a horrible disease that can happen to the nicest people. My patients are the nicest
Oh my
people.
gosh, they're absolutely lovely.
Yeah.
So yeah, after Debbie Downer, we'll run through some U.S. and California trends. I am the data geek in the family, even though he's the history geek, so as you can tell. But
Does that mean we're both geeks?
yeah, for sure.
Dang
For
it.
sure.
Okay.
Yeah. So in 2021, we hit a new milestone as drug overdose deaths topped over 100,000 annually. That was the first year. Fortunately, in the last couple of years, we're seeing a little bit of an improvement, but here's the history. So as you can see, we started this work back in 2013. Actually, I started on more of a micro scale back in 2005. And so this has been going on for a while. But as you can see, for these last several years, this is the trend. These are drug overdose deaths by drug or class for the years from January 2015 through 2021. And we'll get more recent data very shortly. But as you can see, the synthetic opioids excluding methadone, okay, so basically fentanyl, this is the trend in that line. And we'll keep running through these slides.
Really the point of this is to realize that the drastic increase in opioid overdose deaths in the last 6 to 8 years is really all driven by fentanyl and its analogs.
Absolutely. And sadly, as a person who is ER trained, right? We take care of kids, we take care of adults, we take care of anybody, and anytime, anywhere, anyhow. And so I'm very comfortable taking care of kids. Well, so I am one of the docs that's very comfortable taking care of our children that are getting exposed to fentanyl and to the analogs. And so the teens, the middle schoolers, because this is so pervasive and so throughout the community, we're seeing both fatal and non-fatal overdoses in a lot of our kids. And so this is a big reason for us as a community to decrease the exposure, to decrease what we can do to protect these young lives. All right. And so I'm going to share with you some of the data that exists for local communities. We're obviously going to show you Monterey because it's kind of where we are. But you can pull this for your community and kind of give that information to your family members, to your schools when you're asked. I mean, as community leaders, this is, I think, important for you to have. So this is going through the California Overdose Surveillance Dashboard. This is the fentanyl overdose death rate for the total population for California. And as you can see, it was right here about 2016 that we started seeing fentanyl in Monterey County. As you can see from then, it's just been an exponential climb as we're going just for the fentanyl overdose related deaths.
The combination of the isolation of COVID and the arrival of fentanyl was just a deadly combo. Just look how quickly that rises going through 2020.
Yeah, absolutely. All right. And then looking Monterey compared to the rest of California, all opioid related overdose deaths for this time frame that we're looking at. And as I mentioned, in 2013 is when our efforts started. And if you look at that, in 2013, Monterey was in the top third of counties across California. I mean, we were unfortunately seeing a lot of deaths at that time. One thing that we were fortunate enough to be able to do is form a coalition, start working with our local partners. We were able to educate the providers, educate the communities. We were able to stop that flow of opioids, those new starts back in 2013. And we saw a pretty tremendous decline. And we were really pleased with ourselves. When 2019 came around, we were number 2 from the bottom of all the counties in California for our opioid related overdose deaths. And I remember Casey and I were talking about it like, what do you want to do this year? We've already put in drug bins. We've already got Narcan and with our law enforcement teammates, what do we want to do? And then fentanyl came. And as you can see in 2019, California just soared off. I showed you those earlier graphs. And you can see that California really jumped. Monterey was following that same trajectory, but we doubled down. We kept talking with our partners. We had each of our partners do outreach. We started getting into the schools. We started trying to help people understand there's a giant risk here and we need you to know about it so you can make informed decisions and share with your families and your friends and the people in your local COSM, your local community, what we can do to keep ourselves safe. And so we have leveled. And as you can see, 2013, it was kind of up and down, but again, we're still in this fight. We haven't won, just to say it. And so we just want to show this graphic as a way to kind of see where the rest of the state is, where we are in Monterey, and some of the things that have shown some impact.
The dog came for emotional support.
Yeah, she's very helpful with very little. If you remember that last graph, you can see that this is really fentanyl. Right? If you can almost kind of overlay them, you can see for California the rates, you can see for Monterey, and these are the fentanyl specific related overdose deaths. So our fatalities are basically from fentanyl, all of those increases we were seeing for all of those years. Now, wave 4 is something Casey hasn't mentioned yet, but it's something we need to talk about, and that is the combined opioid and psychostimulant. So that's our methamphetamines, cocaine, and how those are related to our overdose deaths. And now we are definitely seeing in this delayed fashion as 2019, things were jumping up. We're also seeing a lot of these co-ingestions, and I think it's multifactorial. One component of that is a lot of my patients, you need something to come down once you've been up, or you need something to come up once you've been down, and so you use meth and or a stimulant. Let's just say meth because that's what we have so much of here. But you use a stimulant and an opioid in that method. Or what we're seeing very commonly is you can't pull them apart. So a lot of my patients will come in and they're, hey, I'm doing great. I'm not using any heroin anymore. I'm not using any fentanyl. This is great. And I test them and it's positive. When we talk about it, it's okay. So you're getting the fent in your meth, and my patients are very well aware. And actually, that's what gets a lot of my patients into treatment. If my patient's not ready to quit a stimulant, if with whatever the meth is doing for them, they need that can at this time, but they don't want to die of the opioid. And so I have countless at this point patients that are actively in treatment. They see me regularly, they take their medications, they follow up with me, they get their shots, they see the team. They're still using stimulants, but they're surviving the opioids. And so it's a really weird thing I started doing several years ago. People whose drug of choice is not fentanyl, they can't get away from it. And so what we do is we put them on medication to protect them from dying from the fentanyl in their substance of choice. It's really a bizarre thing every time I'm having these conversations with patients, but this is what we do and this is what we see. So we wanted to share kind of where that comes from and some of the history with it. Okay. So fortunately, as I mentioned, we are starting to see some improvement. It's not massive. We're still on that giant y-axis that had to be changed about 6 years ago to capture all of the deaths in comparison to prior to about 2019. We haven't dropped the axis yet, and we probably won't for a while, but you can see we are having some improvement. And I think this goes to all of us as a community really trying to do our part. I remember many years ago when I was in the middle of this fight, and Casey teases that, everything in our house kind of floats downhill, and so I drag him into all my projects,
That
which
is that is
completely
100% true.
Yeah,
Do
completely true.
we just agree at the same time?
Completely true.
Yeah.
But with that, he said to me one day, he's like, "What are you doing? You're not going to win this fight." And I told him, I said, if one prescription is prevented and one person doesn't suffer and one family doesn't have to go through this and the ripple effect of what those families experience, then I win. And it's truly that I think we're starting to see is people are realizing all of the efforts matter, and what we can each do as an individual part of our community makes a difference.
Yeah, there's some conflicting thoughts on this. So this is also a national trend that drug overdoses seem to have peaked somewhere in 2024. One theory is fentanyl's killed so many people,
That's
there's not that many people that want to use left compared to when we started, which is pretty dark. There's a belief that we've gotten naloxone out and normalized it, and we're saving people. There's some thought that, expanding access to addiction treatment's been helpful. There's, education about fentanyl has pushed people away from it. It's probably all the above.
Yep. And I think that's the answer is yes. All of the things that are happening matter. And I'm very grateful for what we're seeing. I'm fingers crossed that we continue to see some positive movement. But as you can see, as all the other graphics, when you go through all the deaths and you overlay it with just the fentanyl deaths, it's the same graphic. So same kind of a thing, seeing a decline and hoping. I mean, we're nowhere near pre-2019, but at least we're heading in a better direction than we were. Okay. Same thing with the psychostimulants, and that goes back to the fact that this is mainly related to just fentanyl as an isolated product. Okay. And you can see here, and if you want to pull out your county, but you can pull out your county and see this is the all drug-related overdose deaths for 2024, which is the most complete data that we have at this time. 2025 fatality data is still preliminary. But as you can see, there are certain counties that are still really, really struggling. And there are some of our counties, unfortunately, ours is one of them. And I do believe it's with a lot of this effort that we've been putting in that are at least having some improvements. So definitely check out your counties. And this also is to remind me that most of the counties, as I mentioned back in 2013, we put together our local coalition. We brought in the firefighters and the cops and the hospital administrators and the ER docs and the pharmacies. We brought in everybody. Those local coalitions exist across the state. So if you want local resources, if you need information for what exists in your area, look for your local safety opioids or medication safety coalition. Some of them are opioid specific in the title and some are not, because they're going to have some good information and things that they can share with you. I spent so much time with this. So this is a software, web-based software platform called OD Maps. We have been using this since 2019 when we had what Casey and I have always affectionately called Fentanyl Weekend. That was when we had 10 calls from our local emergency department physicians, because we were them, and a bunch of our buddies called like, oh my gosh, something's going on. And we had 10 fatal and non-fatal overdoses in that single weekend. And we rallied, we pulled all of our partners together. We all got in the same rooms and we were just, what are we going to do about this? And somebody said, well, are you guys using OD maps? What's that? And this is what it is. So this we've been using since then. A lot of you will have access to this through your local safety coalitions, but all the circles on this map represent a reported, and I'm very clear in that term, reported non-fatal overdose. And the colors represent whether or not naloxone was used or known to be used in that situation. And the diamonds are the fatalities. And so as you can see, for this time that was captured, there were 931 suspected overdoses in Monterey County, suspected and reported, very important. Of those, there were 130 fatalities, and we knew that naloxone was used in 419 of them. I say reported because in my street work, if it is not every single shift, it's multiple times per shift. A patient will tell me who they saved or when they did a save, and none of those are reported. This is a database mainly on EMS data. So if the paramedics are called and the ambulance is dispatched, then this data is put in. So this, as I affectionately consider it, is more like the snowflake on the iceberg of what is actually happening on the street or in the community. But it is the best data we have. And so for your region, you may be able to find this information. I'll never forget this call. 2022, our DA called me and was just, oh my gosh, we just see 65,000 fentanyl pills in Salinas. And I mean, that's really tip of the iceberg as well at this point. Our law enforcement teammates are doing an incredible job of trying to curb supply, trying to decrease the influx into our community. Salinas, Monterey County is very kind of a central place for a lot of our drug cartels. It's where the Norteños and the Sureños tend to, there's a lot of cross, what do you call it? Cross cohabitation?
It's contested territory for drug
Thank you.
dealing.
Cool. And so unfortunately, this is where we do have a lot of supply coming in. And when this whole thing started in 2019, we were talking with our Santa Cruz teammates, like, oh my gosh, fentanyl's here, and here's what's going on. And they were like, what are you talking about? And 2 years later, it hit them. So it is regional, and it's amazing the quantities that are coming in. And I think the next slide is even more impressive. So yeah, this deal was just insane. This just went down, and actually, it's really interesting because I chat with a lot of my patients about this deal that just went down and how it really changed our local market. For a while, people had already purchased from this conglomerate. They'd already purchased, and so for several weeks, there was really no big change. Everybody had that supply, and then that supply ran out. And so then they had to figure out the new dealer, for lack of a more intelligent word right now, but they came up with new supply chains and how to get the drugs into this community. And so we talk about it as whack-a-mole. Unfortunately, as long as there's demand, the supply will continue. But it's mind-blowing what we are seeing as it's coming through. And so this is that the most recent bus that went through this one.
This is from November.
Yeah. So, among the narcotics seized at the end of October, there were 23 pounds of fentanyl. And as you heard, 4 grams is enough to kill 2,000 people. So, this 23 pounds was enough to kill the entire population of Monterey County 12 times over. So supply is clearly not our problem. They also had a little smattering, 1 ounce of heroin, 11 grams of
Doesn't hair
cocaine.
anymore.
My
Heroin's
patients thought
gone.
that part was hilarious. That
Oh.
was conversation in the office, yeah, for weeks. Yeah, so this is where we are now. Yeah.
Okay.
Oh, yeah.
So we usually divide this presentation into two pieces. The first is trying to understand how opioids do what they do, how we've evolved over time, and where we're going to focus on the rest is trying to understand how we can avoid causing harm as healthcare providers when we have to treat pain. So these are some of the points that are required for the course. So the first is so-called red flag behaviors. Now, what is this reference? We all know as healthcare providers that sometimes patients say things that just don't quite add up. And a lot of what this represents is what used to be called drug-seeking behavior. And drug-seeking behavior is what it sounds like. People are doing things to try to get more of a particular substance. But drug-seeking behavior is not a definitive diagnosis, right? So let's say somebody comes to your office and you suspect that they're trying to get more prescription opioids from you. Do they have an opioid use disorder? They're addicted. Do they have opiate dependence and they're in withdrawal? Do they have severe untreated pain? Do they have severe untreated mental health and the downer effect of the opioids is soothing? So a red flag behavior is something that suggests that the patient is trying to get more opioids, whether they're bargaining for the amount, they seem unusually savvy with the names, they ask about the dose, the amount, the route of administration, they come in frequently for refills. That is a flag to you to ask more questions because it could be that they have untreated pain, dependence, addiction, all of the above. So the first thing we have to really understand is that pain is complicated. So we partner with a pain medicine practice in our office. It's addiction medicine is one service line, pain is the other. And again, I chaired the hospital's pain committee for, I think, 6 years or 8 years with one of the physicians that we currently work with. So the first thing is not every diagnosis requires opioids. So I remember when I was a little baby doctor, someone sprained their ankle and I went to write a prescription for 30 hydrocodone. And I was like, wait, 30 hydrocodone? Huh. I don't know if they need that. Same thing. I had a gentleman come in with, gastroenteritis and he was saying his stomach hurt and I went to prescribe 20 hydrocodone and I was like, for gastroenteritis? Really? So the first question is, does the diagnosis warrant opioids? And we'll hear our colleagues in pain medicine talk about this, be like, oh my gosh, their spinal diagnosis is so severe, I do think they need an opioid. The next thing is untreated mental illness is associated with addiction, whether it's anxiety, depression, PTSD, bipolar, ADHD. Most mental illnesses increase the risk of a person developing a substance use disorder. So if the patient has severely untreated anxiety, maybe now's not the best time to do a large procedure that's going to involve a lot of prescription opioids afterwards. Maybe let's get their anxiety a little bit better controlled, and then they won't be drawn to the downer effect of the opioids to quell their anxiety.
When we talk about it as self-medicating, and when you approach the patient with that, it tends to be better received. Giving it a title is not they're doing anything wrong. It's just I understand that these medications may be soothing, or that people tend to self-medicate with them.
But if you think about it, right? So let's say one of our patients uses fentanyl. They are willing to spend their time to get it, their money to get it, and take the risk of getting arrested or overdosing to get it. They clearly psychologically, physiologically need something. So a lot of what we do as addiction doctors is find out, what is it you need? Are you not sleeping? Have you been horribly traumatized by being abused as a child and you have all these flashbacks and intrusive thoughts? So that goes back to when the patient says something that triggers your radar, this is a red flag, we need to dig further into why. There are 4 major risk factors for addiction. This is really dumb, but an active addiction.
To anything.
Right. They call it cross addiction, where you get addicted to one substance, get better, and then go to the other. The second is a history of addiction. Once you have an opioid use disorder, getting back on opioids is a major red flag, or excuse me, a major risk. Reb, when was the last time you rode a bicycle?
It's been a bit.
Like, would you say 2 years? More?
Probably.
3 years?
Yeah.
Could you ride a bicycle today?
Yes.
Yes. Our patients, 3 years sober, can go back to opioids very quickly. One of my patients today, crying and crying and crying, she had 3 years of sobriety from opioid use disorder and she relapsed. Okay, the next major risk factor addiction is a family history. I mentioned that some people, when they consume an opioid, they get an intense euphoric response, a sense of well-being, a sense of tranquility, even more energy. Sometimes people find opioids activating. Like, oh my gosh, I'm so much more productive on opioids. That comes from family history. So if addiction tends to run in a family, that's another potential risk for addiction. And then the last is severe uncontrolled mental illness for the reasons that we talked about. Now, when we go to prescribe an opioid, should we be doing an informed consent? And the answer is probably yes. Our pain doctors document very specifically in the chart. I counsel the patients on the risk of tolerance, dependent, a use disorder, overdose, and based on their diagnosis and their and my understanding of the risk, we feel a trial of opioids is warranted. We'll talk about why a trial is important. It may be reasonable to have patients sign an agreement that they understood what they're starting. The other thing is once you start an opioid, we want to see if it works, right? What's their pre-pain level? What's their post-pain level? If it's not making a difference, then we shouldn't continue to prescribe it. The other thing is, and don't get me started on pain scores. Oh my gosh, pain scores. Think about this. If you told me as your patient, if you're a 1 to 3 on the pain scale, you get Tylenol. If you're a 4 to 6, you get ibuprofen. If you're a 7 to 9, you get morphine. And if you're a 10, you get a free Lamborghini. Well, guess what? I'm a 10. 10, 10, 10, 10, 10, 10, 10. In fact, I'm so much a 10, I'll take 2 10s, 2 Lamborghinis, please. Literally at the hospital, we use patient reports through the pain scale to guide what medication patients are getting. And it's frustrating. The patient will be a 9 and say, I think acetaminophen is going to be enough. And the nurse is required to give morphine because that's how the order is written. So it's really not about the pain number unless you're managing chronic pain over time and you're trying to get a sense of the trend in pain. Like if a patient goes from a daily 5 to a daily 3, that's a win. But if you're looking at like pain after surgery, just no, the pain scale is hard because everyone experiences pain differently. Really what we want to be looking at is function. You guys have all probably seen this. Someone says they're a 10 out of 10 as they're posting on Instagram and eating Doritos. Okay, sure, this may be the worst pain you've ever had, but it sounds like you're able to tolerate it. Maybe we don't need to use an opioid. Let's go a different direction. Or on the flip side, somebody's like, Doc, I'm a 2, fine, totally fine. And they're like, they can't get out of the chair. It's like, okay, your pain's more serious. So we really want to focus on function. The other thing is if we do start an opioid, we want to start it with something else that's called multimodal analgesia, which we'll spend quite a bit talking about in just a little bit. And then again, if you start an opioid, just a reminder to go back and reassess. Now, if you're an acronym person, I love acronyms. If you're going to prescribe an opioid, go through your 4 A's. Does it provide adequate analgesia? Let's focus on their function or activity. Are they having side effects? And are they starting to develop an addiction or show aberrant behavior? And then the last thing is it's a controlled substance. You obviously need to be documenting when and why you're prescribing it and if refills are warranted. Do you want to talk about cures?
I can.
You love cures.
I know. You've been working with the team with cures forever, it seems at this point. Basically, that is our prescription drug monitoring program, our California database. And the reality is I use this in every possible way. And for every patient that I prescribe any controlled substance to, or if I'm prescribing a non-controlled substance that I'm worried about medication interactions. It's a database for all of the schedule. Is it still only two?
It's schedule 2 through 4, and some pharmacies report schedule 5, but it's optional.
Yeah, 5 is still optional. Okay. So the bottom line is it's helpful on both ways. So if I go to prescribe something and I see that there are 10 doctors and 10 pharmacies and 20 prescriptions, I need to chat with my patient because there is some concern for their safety. Clearly, they may have an agreement with one of these providers, and if that is the case, I could, and I explain this to patients quite not as frequently anymore, but I used to, about if I were to prescribe to you, your relationship and the trust that you have with Dr. So and so, that could be changed and it could violate your contract. And so I bring that up as a conversation piece with them. So you find something that's concerning to you for their safety or for the safety of their treatment, and you bring it up to them. And that's how I've always handled it is, hey, this is a piece of data. Let's use this together and figure out a best management plan. On the flip side, Dr. Close every month, Dr. Close every month, Dr. Close every month. You see that someone's engaged in treatment and they're doing what is being asked of them, their provider, they're following up as scheduled, and you'd want to know that too. So I have a patient and you see them and you see buprenorphine close, 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 straight down, and you're about to do a procedure and you're going to consider that that patient may be a good candidate for opioids, call me. You know they have a relationship with a provider, and you can say to them, hey, I see you're on buprenorphine. I need to talk to your doc so we can make sure we really well manage your pain.
And we'll talk about managing
Oh, I do it all the
pain
time and love it.
with buprenorphine in just a little bit.
Awesome.
We'll dig a little bit more into the cures in just a little bit, but just an overview. You can basically log in and look up to see whatever controlled substances your patient is getting.
Yep.
Yeah.
An exceptionally helpful tool to use when you discuss with your patient.
Okay, so we're going to go through 8 things that you can do in your practice fairly easily that will help in a number of ways, whether it's treating pain, understanding how to help people with addiction, if they're in recovery or they're in active addiction, and then just around medication safety.
Yeah.
Number 1.
Stigma, stigma, stigma. So people with substance use disorders are one of the most stigmatized groups in our society. I mentioned to you the patients that I take care of in the jail, the patients on the street. This is a horrible disease with an incredible amount of stigma with it. And I don't know if you have noted yet our language, but there are just terms I will not use. And even in teaching, I can't use these terms. So you will hear me say a person with opiate use disorder, a person with a substance use disorder, a person in recovery. The one theme there is a person with. These are people. And I know hearing that overtly just seems like I'm crazy to have to say it, but these are people. You know, I even find myself for my patients with diabetes, there it goes, you know, it's not Joe the diabetic, it's Joe the gentleman with diabetes. These are people that deserve as much care and kindness as you would treat any other patient with. And this judgment is so inherent in our society of the us them thing. And I think it's protective. You know, it would never happen in my family. It's those people. That's actually not true. And so keeping in mind that these are our peeps. That's what I say all the time. And so using that person first language, avoiding terms with judgment. And I find the easiest thing is correcting my staff. We did this in the ER all the time. You know, oh, the addict in room 5. And I'm like, let's tone down the language. The gentleman in room 5 is suffering with addiction, and just keeping in mind that these are people first. And so I tend to get a little ranty about stigma, because actually I lost someone to stigma. One of the people we were taking care of, he was on the street with me caring for others while he was struggling with his own sobriety, but he was present in a way that I can help people, and he was amazing. And when he needed medical care, he didn't go because he knew he was going to be judged. He knew he was going to be treated like garbage. And so he died. And his cause of death was stigma because he was so afraid because he'd been treated so badly for so long. So if I can implore you to just consider the kindness and the way that you approach these patients may change their experience with the medical community in some positive way, I'm going to ask for that, please.
Yeah, there's a couple more parts to it. So there's something called diagnostic overshadowing, which is where once you identify a particular diagnosis, and not you, but like the greater you of us as healthcare providers, once a healthcare provider makes a particular diagnosis, they're often not willing to continue to investigate. So I hear this a lot, like, oh, such and such happened. Oh, he's a druggie. which means you don't have to continue to do a workup. You don't have to continue to keep him admitted. He doesn't need surgery. I hear it a lot from my surgical colleagues of just like, oh, no wonder he's difficult. He's a druggie. It's like, well, but there's so much more to the story. We'll talk about opiate-induced hyperalgesia. We'll talk about how certain opioids actually increase pain paradoxically over time. It is so easy to just look at something and say, well, I know what it is because they have an addiction. And there's often so much more to the story. True story. I almost killed someone having that same stigma around anxiety. I was working in the ER and a young lady came in and her chief complaint was really vague. She was like, I just don't feel right. And I'm like, oh, let me guess. Another 22-year-old girl with anxiety. She had adrenal insufficiency. I am so glad I at least stopped to check a couple of basic labs because her sodium level was so low she had to go to the intensive care unit. That was very humbling for me. And I've definitely had patients where we're like, you know what, it's the drugs, it's the drugs, it's the drugs. And then, oops, somebody investigates and it's more complicated. And one other thing, just coming back to what Reb said at the very beginning, poor dentition is so stigmatized. So, to all of you who help any human being on planet Earth be able to smile and feel confident, thank you so much. And when you have more than one stigmatizing condition, it just kind of goes upon itself. Let's say you've got bipolar and you're unhoused and you've got an opiate use disorder and you have no teeth. Just nobody's going to give you the time of day. So trying to create a safe place for people really helps. And I think if you come into a situation of like, I'm really worried about you. I saw that you've been getting a lot of prescriptions. I want to make sure we're doing the best for your healthcare rather than coming in and being like, you're getting drugs from everybody. Really coming in with like asking some open questions. Are you doing okay? Is your pain managed? Should we get you referred to pain management? Do you need to see a primary doctor? Really trying to create a safe place makes a big difference. Okay. The next thing is really making education easy and accessible. So, a lot of what we do as healthcare providers is the same thing over and over and over again. How many times have I walked into a room in the ER and be like, hello, I'm Dr. Grover. How are you today? I'm going to clean my hands for your safety. I'm going to close the door for your privacy, right? Hey, I understand you don't think you need a prescription for naloxone, but let me give you my spiel. We do the same things over and over again. So it can be very easy to kind of create a standardized handout to just put in the waiting room, like just facts about pain management after a dental extraction. And, or hey, you know what? We're going to have to do an extraction. Let me just give you my usual handout. It gives you all the things I recommend patients after an extraction. So for our Monterey Bay Dental Society dentists, we actually also have specific information about resources about addiction or addiction treatment. You can just put that in the waiting room, and even if it's not your patient that has an addiction, but a loved one, a brother, a spouse, a kid, they can just kind of quietly put that in their backpack or purse, and then it gives them some resources. So when it comes down to, I'm going to prescribe you opioids, it's the same conversation. These are not risk-free. They can be addictive. We want to use the lowest dose for the shortest duration. We want to treat your pain, but we just have to be careful. Sometimes when I'm worried about someone, I'll actually go through and ask them, there are 4 risk factors for addiction. Let's see which ones you have. And even say, like, I don't know that you're a great candidate for opioids. Okay. We want to make sure we counsel patients. They have side effects. There are risks. There are alternatives. Many years ago, people thought it was from a doctor. It was no big deal. Now we get people saying, I really don't want an opioid unless I need it. We're going to talk about multimodal analgesia in just a second, but you can actually write out some prescriptive ways to manage pain. What we do know about pain is it's much easier to keep it under control rather than rein it back in after it's out of control. So being proactive after a surgery, a procedure, an extraction is very helpful. Children. So children and teenagers, and I know you all know this, particularly you with kids, children and teenagers' brains are wired differently than adults, but I'm referring to a very specific way. There is one chemical in our brains that is associated with pleasure, and that's called dopamine. And we talk about it all day long in the world of addiction medicine because a lot of these addictive substances or behaviors like gambling or social media release dopamine and trick our brain into that this is something that's good for us. It turns out children and teenagers release more dopamine than adults do when something new happens. And children and teens release less dopamine on an average day, so they're more prone to boredom. So the earlier a child is exposed to drugs and alcohol, the higher their risk of addiction. So in children and teenagers, opioids are like the absolute last resort. And if you do decide to prescribe them, it's a very small quantity, a very limited duration, and the parent controls the meds and understands their child's future is literally in their hands. Maybe that's a little hyperbole, but
Or not.
it does happen.
Yeah.
Teenagers, I think, as well, as they age, they start to get into experimentation. Maybe they do great with a small prescription for hydrocodone after an extraction, but we want to make sure that's not still in the house for them to want to try or give to their friends to try. A lot of people talk about getting started with experimenting with substances with old prescriptions in the home. People with multiple medical conditions, this gets really hard. People on blood thinners or with kidney disease can't tolerate an NSAID. Somebody who has an allergy to acetaminophen can't tolerate that. We'll talk about the various ways you can kind of incorporate as many different pain pathways as possible. Again, that's called multimodal analgesia. But with sometimes if people have a lot of medical conditions and you expect it's going to be a lot of pain or a big surgery, it actually makes sense to actually have them see their primary just to come up with a plan for pain management given the medication interactions before you feel like you're willing to take on that level of procedure. Patients with opioid use disorder. Let's say someone comes to you and they're like, Doc, I am 3 years in recovery from fentanyl. Please do not give me opioids. We'll talk about how to manage that if they're on a medication like Suboxone to treat their addiction or not. And then if people are in active addiction, it's really hard to manage their pain. Their tolerance is up. They're more sensitive to pain because they're on opioids, which we'll talk about in a little bit. But it may be something where you want to ask them to see their addiction doctor or talk to their sponsor in recovery to come up with a plan for if it's going to be a big procedure and you feel like you need an opioid, how you're going to manage it. The best answer is don't give opioids unless you absolutely have to. And if you have to, just like in the most controlled setting possible, even if it's like one dose in the office in front of you as they go home and then they discard the prescription. The more supervision, the better. You can enlist family members, sponsors, other doctors, drug and alcohol counselors, friends, family, whoever you can to build that network of accountability of saying, we have to get this done medically, but this is how we're going to take extra precaution.
Naloxone. Yeah, so we in our community started putting naloxone anywhere we could as early as possible because if someone dies of an overdose, they never get a chance to recover. Never. Or the inadvertent exposure for a child or an elderly adult who gets their medications confused or whatever it may be, this is a life-saving medication. So if anyone isn't familiar with it, naloxone is basically the antidote to an opioid. Doesn't do anything for benzos or meth or anything else, but if there's an opioid associated with the overdose, then naloxone is the antidote or the cure for that. Short-lived, short-lived. It's not one of those things that one dose of naloxone and you're good and done. Now with fentanyl in basically everything, multiple doses of naloxone may be needed, and patients really do need definitive evaluation or treatment. How do you approach this with patients? That's where this is really important. We have a naloxone Christmas tree, literally, like it's a Christmas tree, naloxone on it as ornaments in our office, and we have an naloxone box out of the front of our office where in the middle of the night you can walk over and grab a dose of naloxone. We put them, they're old newspaper boxes, like like the old open it, grab a newspaper and leave boxes. We put those all over our community and literally you just walk up, grab naloxone and walk away. Like, I don't care. Just grab it. Go, please. Thank you. Thank you for saving a life. As a provider, if I've decided that I believe it's warranted for someone to have an opioid, a full agonist opioid, as we kind of call the global, use the global term for them, I will also co-prescribe naloxone. That conversation feels a little weird sometimes for people. And even our patients that are in active addiction will say, well, I don't need Narcan. I don't hang out with those kind of people. And you're just, oh, only. I tell a couple of stories. Okay. So I was going to the opening for Monterey County of a naloxone vending machine. It's free. You walk up, you type in, I think your age and gender or something, and out pops naloxone. Okay, totally free. It's an awesome thing. So I am driving with one of my colleagues to that event. Okay, and we're driving along, and we see somebody slumped over, kind of laying down on the sidewalk, and someone's standing over that person with a telephone or with a cell phone. So we stop, of course. Why wouldn't I? Skid across the thing. I grab my naloxone and run over. And, we call 911, we administer naloxone, we do all the stuff that we do. I wasn't hanging out with those people. I wasn't in a bad situation. I was driving a car to an opening event for a community service. So realizing that the medications and these substances are so dangerous that we want naloxone in the community is the way that I've learned to approach this with patients and community members. So it's not you, patient, are being judged, and I think you need this medication. It's these medications. This medication I'm going to prescribe to you is so dangerous, I want you to have the antidote. And so, literally, just a little bit of framing and a little bit of perspective on what this means in a community is, I think, the best way to approach this with a patient. And I see that barrier coming down. And when someone's like, well, yeah, okay, I'll take it. I'm like, thank you for being willing to save a life. I mean, truly, that's what this is it's a life-saving medication. The other thing is if you mention pets, people are all different, or the elderly or kids, people understand it's not about them. It's about vulnerable and helping people in the community. So
No, truly, if someone's got Vicodin, or excuse me, Norco or hydrocodone in their purse, and the dog smells the treats in the purse next to the pill bottle and eats it, and the dog can overdose, naloxone works on dogs.
yeah, and the naloxone nasal spray, which of course it's on our desk. The naloxone nasal spray there's no needles, there's no concern of any injury if somebody is not overdosing and they get naloxone. Casey and I together probably have several hundred doses over the years because we do it for demonstrations. And no, it is what it is. So there's no harm, no foul if someone is not having an overdose, but if they are and they need naloxone to reverse that opioid and you delay it, they could suffer a fatality or irreversible damage. So it's important. I'll be done with that.
Well, the other thing, and just to Reb's point, is if you just come in and say, look, I'm going to prescribe you medication. I know you're careful. I know you're careful.
Yep.
Accidents happen. I am a responsible homeowner, but I have a fire extinguisher in my house just in case. I think I'm a good driver. I also wear my seatbelt just in case. Think of the naloxone as, oh my gosh, the worst thing happened, such a freak accident, at least you'll be ready.
Yep.
And worst comes to worst, you're done with your prescription, put it in your glove box, you could save a life. So that's another way to, again, kind of reframe that.
Yeah, and so as we talked about with cures, and we'll go through this pretty quickly, but truly checking the prescription drug monitoring program just as an information tool before prescribing a controlled substances, it's actually the law, so you should probably do that. But you will be amazed at what you see and how that can frame your conversation with the patient. People that are at higher risk of overdose would be those already on opioids. So if they already have a prescription for hydrocodone, they don't need a second one. Thanks. Patients on benzodiazepines, obviously, mixing sedatives is obviously more dangerous. And then you may see evidence that there could be an active use disorder, and you can bring that up with the patient. It's truly just a safety issue. Cures, I love it. I'm in it. Oh, a complaint I hear about cures is it's hard. No, it isn't. I'm in cures every freaking day, all day long. It's a couple of clicks and it's a huge amount of information and it's the law.
You can also assign a delegate in your office that can prepare your cures reports for you.
Yep, they can just pull it for you. So,
yeah, the one thing I just wanted to point out is, Reb, what would you see in a cures report that makes you think somebody has a use disorder?
Oh, and that goes back to what I mentioned when we were talking on the other slide, multiple providers, multiple different classes of medications, potentially even early fills, multiple pharmacies. It was easier before cures to go to 10 docs, 10 pharmacies, and get 25 different prescriptions. It's harder now because of cures, but those are the things I look for. And when I see it, I'm like, whoa, wow, we're on benzos from from your psychiatrist and you're on opioids from your orthopedist and your family doc is giving you soma. Whoa, holy smokes,
Well,
we need to talk about
that
this.
might be polypharmacy, where a person is just on too many different meds and the
Absolutely.
risk of side effects and potential overdose goes up. I think what I look for when someone has an opioid use disorder and opioid addiction on cures is just no consistency. It's like 10 pills here, 8 pills there, 2 pills there,
Or like
frequent
ER fills. I
frequent
got you.
fills, going to the ER. Oh, my podiatrist filled, my dentist filled, my
Good point.
the veterinarian filled for my pet. We really, to be honest, don't see that anymore. As you heard, we had 23 pounds of fentanyl in Monterey County. People don't really get prescription opioids from the illicit market anymore because we're doing presentations like this. If someone's on methadone at a methadone clinic, it will not show up on cures. They might not think to bring that up. And then medicines from the VA, the Veterans Administration, do not show up on cures because they get dispensed on federal property, not state property. If someone's out of state, sometimes the PDMP will show it. There's actually now in California's cures, you can get nearby states. But if someone goes from Alabama to Sacramento and you're their provider, you may not be able to see it. So it's important to know like what it has and what it doesn't have. Now, on the flip side, with what we do, when somebody's got addiction and they're doing great on Suboxone, which we're almost going to get to, and they go out of state, I actually print them out a copy of their cures and I give it to them to take to the pharmacist of like, I just moved. I saw my addiction doc last week. Like, here's like, if you want to talk to him, because we want to, maintain continuity of care. So it's not perfect, but I think if you go in being like, oh man, this guy's totally looking for opiates, and you find that it's like the same doctor, the same pharmacy, once a month, no early refills, you're like, oh, okay, cool. Well, if you've got pain, let's work with this doctor. Or sometimes you'll see that the person's really just in too many different pharmacies and getting too many different prescriptions.
The pharmacists have access to this too, so you know.
Thank you.
Yeah.
Okay. Multimodal analgesia. This really I think you'll find is extremely high yield. So I think we used to think of pain treatment as monotherapy. Let's try an acetaminophen. Give it a few hours. If it doesn't work, try ibuprofen. If that doesn't work, try a hydrocodone. No, 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 no. We give everything all at once to maximize the number of analgesic pathways through the brain at the same time. Can you use a local anesthetic, right? That's a sodium channel blockade.
Oh, good.
Can you use acetaminophen? We actually don't know how it works. Can you use an NSAID? That's a cyclooxygenase inhibitor. Can you use a gabapentinoid? That's modulating the GABA receptor, right? Can you use a non-pharmaceutical way of treating pain like cryotherapy? They all add up. And it's actually 1 + 1 + 1 is 4, meaning they actually have a greater analgesic effect than the combination of the individual medicines combined. So we literally did this for years at 2 a.m. in the emergency department. Someone has some sort of dental pain. You know, it's usually some sort of like pulpitis or, periapical abscess. Occasionally we get a pericoronal abscess, but somebody comes in and like, doc, that tooth hurts and it's 2 a.m. I'm like, I got you. We'll put in some local anesthetic like bupivacaine. We'll add in acetaminophen. We'll add in an NSAID. We'll sometimes add in gabapentin, depending on if they're getting some regional pain as well. And then we'll just kind of watch them for an hour and see how they do. And they're like, you know what, doc, I can sleep. I'm going to go home.
Mm-hmm.
Sometimes we give them a single dose of an opioid in the emergency department and then send them home and they're going to get like 1 or 2 day follow-up with their dentist. But you can do so much by not kind of doing one at a time and really putting them all together. So this is best practice. We do this at the hospital for post-operative pain. We do this for fractures. This is best practice in pain management.
And I will say something about that is I tell my patients this isn't take it as you're needing it. This is around the clock. And I had this conversation with a patient today who is scared to death to follow up with her dentist. And so we were talking about, I'm like, okay, we talked about how I can get her there and what we can do, but we went through, I'm like, okay, I need you taking acetaminophen, not just to treat the pain, but to prevent some of the symptoms. So I'm like, this is around the clock for the next several days. Your NSAIDs are around the clock for the next several days. We talked about cryotherapy. This is something we need to stay ahead of. And I find it to be incredibly helpful for a lot of our patients.
Now, we love NSAIDs,
Mhm.
but NSAIDs there's a little more to the story. So, just to level set, I know you all know this, but non-steroidal anti-inflammatory drugs, things like ibuprofen, naproxen, meloxicam, celecoxib, these are the NSAIDs. So the first is, and we're going to dig into this in a little bit, but they are associated with some adverse cardiovascular outcomes when used chronically. So if you do 5 days, you're going to be A-OK. I'll give you the numbers in just a sec. There are various syndromes where people are intolerant to NSAIDs. Sometimes it's the whole class, sometimes it's just one. So usually if somebody says, I can't take that, I ask, well, because we all know ibuprofen and naproxen are over the counter. People will be like, well, I can't take NSAIDs. I'll be like, do you ever buy Aleve at the store? Oh my gosh, doc, I take Aleve all the time. Aleve being the brand name for one of the forms of naproxen. Well, that actually is an NSAID. So sometimes taking a little bit more of a history can help. Um, in terms of drug interactions, hypertension is one of the adverse cardiovascular outcomes associated with chronic NSAID use. I think this monitoring blood pressure for NSAIDs longer than 5 days is a little conservative. Most of the data on adverse cardiovascular events from NSAIDs is like 6 weeks plus of NSAIDs. But if somebody has really difficult to control hypertension, you might just want to get a quick approval from their PCP to do it, or just do 1 or 2 days. In patients who are on aspirin, aspirin irreversibly inhibits platelet function, so they'll have a bleeding risk for several days. Let's say you want to use an NSAID to treat pain when someone's on aspirin. I'd be a little cautious just due to the bleeding risk, but probably best not to take them at the same time. Now, this is something that I did not know. It was not in medical school, and I found it very useful. NSAIDs have what's called an analgesic ceiling, meaning that when you increase the dose above a certain amount, you don't get more analgesia. And we used to, when I was playing high school football, have what I now look back as Advil contests. Like, man, I'm so sore I took 8 Advil. Like, dude, I have it worse. I took 10 Advil. It doesn't do anything above about 600 milligrams. So the analgesic ceiling of ibuprofen is somewhere between 400 to 600 milligrams. Meaning if you give them 800, it may help with inflammation, but it's not going to help with pain. Same thing with naproxen, right? That analgesic ceiling is close to the maximum recommended dose, which is about 500 milligrams. Probably the analgesic ceiling is a little bit lower than that. You can give them a higher dose for inflammation, but it's important for patients to know you just don't keep taking more NSAIDs. Take it as prescribed. And a lot of times, just because it is over the counter, I will specifically prescribe 600 milligram ibuprofen tablets so that patients know exactly how much to take and how often. Okay. The NSAIDs work by inhibiting the enzyme cyclooxygenase, which synthesizes prostaglandins, which are associated with inflammation. So it's actually intuitive that if you give someone an NSAID before a procedure, they're going to be less swollen and have less pain after. Obviously, you have to make the decision as the clinician if there's a bleeding risk, but that can be helpful. So as it points out here, the goal is to block some of those prostaglandins before the local anesthetic wears off so they're more comfortable. The last thing is acetaminophen. We don't actually know how it works, and it's hypothesized that it may inhibit a separate cyclooxygenase enzyme that the NSAIDs don't touch. So bottom line, they are complementary, they work together, and I use them together all the time personally and for my patients. I mentioned the data on adverse cardiovascular outcomes with NSAIDs. This is a meta-analysis from American Family Physician, I think like late 20 teens. I think it's like 2019 data. And what you can see is, yeah, if you give someone 6 weeks of ibuprofen, their risk of hypertension goes up compared to placebo. And if you give someone 6+ weeks of ibuprofen compared to placebo, their risk of stroke goes up as well. Now, I circled in the boxes the ones that were statistically significant. Very few of these were statistically significant, but we have to realize that these meds are not benign. I love to exercise and I'm always injuring myself. And I put myself as a physician, I know you're not supposed to, on meloxicam, which is a generation 2 NSAID. And my PCP was like, Grover, really? And I was like, what? And he was like, didn't you think about hypertension? And I was like, no. So for most of what you all are going to be doing in your practice, 7 days or less of an NSAID is going to be okay unless you hear from their doctor that they have had one of these cardiovascular outcomes and you want their doctor to weigh in. Now, opioids can be a part of multimodal analgesia, right? If you're doing a big procedure and you don't think NSAID, acetaminophen, local anesthetic, cryotherapy, gabapentin is going to be enough, that's why we have them. So, there are basically two types of opioids. The first is what's called a full agonist opioid. It binds at the opiate receptor and activates the receptor completely. And these are all examples: codeine, hydrocodone, oxycodone, tramadol, morphine, fentanyl. Now, there's a couple of problems with these. The first is that sometimes there's a little bit of nuance on how to use them. So it turns out codeine is inactive, and you have to metabolize it to morphine to actually get pain relief. The metabolism varies person to person. So some people, if you give them codeine, they feel nothing. That might seem like drug seeking, but they may not metabolize codeine. Other people over metabolize codeine and they get a huge spike in morphine. So we tend to not use a lot of codeine for that reason. And hydrocodone's actually fairly similar. I briefly just need to get my angry tramadol rant off my chest, and you're welcome to go next.
For it.
Tramadol, it's actually technically should be termed tramadont. And here's why. Number one, it has this reputation as being a non-opioid. That is not true. It is an agonist at the opiate receptor. And it turns out it's also an antidepressant. It works like Effexor, also known as venlafaxine. It inhibits the reuptake of serotonin and norepinephrine. So it tends to interact with psych meds. The other thing, it lowers the seizure threshold. So people are more likely to have seizures. It causes low sodium. It can cause low blood sugar. It has all these side effects and issues that other opioids do not. So when you think tramadol, think tramadont. I saw you shake your head. Let's do that again.
Totally.
When you think tramadol, you mean tramadont.
Yeah, no, I am serious. This medication, oh my gosh.
Now-
People are like, oh, it's not an opioid. What? Yes, it is.
Oh, I was on fire
Gosh.
when the requirement for physicians to prescribe opioids came out. I signed up for a course, like, hey, I'll get my requirement done. And they were like, oh, thank goodness tramadol is not an opioid. I was so mad. I literally contacted the company, like, you are advertising a legitimate education around opioids. This is
With
like, this is
misinformation.
educational malpractice. I love my colleagues, but one of my colleagues was like, hey, Casey, we're doing, laparoscopic surgery without opioids. And I was like, that's awesome. What's your protocol? He was like, tramadol. And I was just like, he went to Stanford too. Anyways, I guess I trained at Stanford too. I'll own that. So the other major issue with all of these opioids is they cause what's called opiate-induced hyperalgesia. Let me explain. The brain does not like to have pain numbed. Pain is protective. If I go to touch my wife and she's about to bite me, maybe that's a bad example.
That's a great example. Go ahead.
If I'm going to touch a stove and I need to feel that it's hot, I need to be able to feel that pain to pull my hand away. When people are on chronic opioids, the brain is worried that it won't be able to feel tissue damage, and so it dials up the pain sensitivity to compensate. And so we see so many people who are on full agonist opioids and their pain gets worse over time because their tolerance goes up, so they need more, and their opiate sensitivity goes up, so their pain gets worse.
Yeah.
So this is really not good practice in pain management, is to prescribe these opioids for chronic pain. 3 days after a procedure, maybe I'll give you some data that may change your mind, but full agonist opioids we do not use in our pain management practice. There are only two opioids that are not associated with opiate-induced hyperalgesia: buprenorphine, which we'll go into detail in just a sec, and methadone. And methadone actually activates a second receptor called NMDA, which actually fights some of that tolerance and hyperalgesia. Bottom line, if you need to use an opioid, again, lowest dose, shortest duration, and these medications hurt people with chronic pain by making their pain worse over time. You love buprenorphine. Do you want to do this one?
Buprenorphine. Okay, so buprenorphine is an opioid. Absolutely, absolutely is. But it's a partial agonist. And so when you have that opioid receptor, which I do this for my patients all day long, I have my little opioid receptor and you bind it with fentanyl or morphine or whatever, it fully activates it, which includes respiratory depression, decreased level of consciousness. It's a full activator. Okay. Bupe's different, binds the exact same receptor. Hallelujah, it binds tighter than fentanyl and morphine and Dilaudid, and you pick it. It binds, it's the tightest uh, affinity for that receptor of all of the opioids, and it only partly activates it. So my patients on bupe, I mean, if you were to give me bupe because I'm completely opioid naive, I would feel it. I would feel maybe a little euphoria, maybe a little lightheadedness. I have no idea. I've never used bupe. But that overdose and death and all of the risks that we see with full agonist opioids, it's just not there. And it blocks that receptor from other opioids. This is why my patients get themselves onto buprenorphine to protect themselves from the opioids in the illicit supply. Is because once that receptor is taken by buprenorphine, it is not available for other opioids, which is incredible. With that, for pain, so you've heard us talk a lot about patients with opioid use disorder, opioid dependency intolerance. For pain, it's completely different in how you need to dose it and in how it works. So for my patients with chronic pain, we actually use buprenorphine, and I use buprenorphine for pain. If I break my femur, this is the only opioid I will accept personally.
And you're allergic to morphine.
Well, that too.
Yeah.
But when you use it for pain, the dosing's different. So a lot of my patients will take 24 or 32 milligrams of buprenorphine first thing in the morning, go about their day, everything's fine, right? They can drive, they can take care of their kids, they can do their job, everything, they're fine. For my pain patients, their dose may be 2 milligrams 4 times a day, or half a tab, so 1 milligram 4 times a day. It's totally different in the dosing. So you can take that buprenorphine dose and spread it out through the day for really good pain control. And it's incredibly helpful for my patients, both with chronic pain that want to be on a safer pain regimen. The difference as well that I see is instead of like hydrocodone or full agonist, where initially one was good for my pain, and then now I need 1.5, and then I need 2, and then I need 4, and now I'm snorting 10, right? So instead of that kind of increased tolerance, bupe just doesn't do that. What I find with my patients is over time, their opioid tolerance and their opioid need goes down because they're not having that same opioid-induced hyperalgesia and not having the same tolerance. So it's incredibly helpful. Just wanted to point out, and I mentioned this, we have a lot of patients on buprenorphine and they have procedures and they have acutely painful conditions and they have surgeries. And a number of my patients have full dental extractions associated with getting their dentures or other dental work done. I keep their bupe. I keep them on their shots. I keep them on their medications. I have them change how they take their bupe. So if they're taking, say, 16 milligrams twice a day, I may have them take 6 or 8 milligrams every 4 times a day, or 4 milligrams even every 4 hours. If you break it up into those smaller doses, they have better analgesia. And so it's really nuanced. That's why I say if you see my name or if you see a physician's name with buprenorphine all over their cures report and you're planning to do a painful procedure, enlist the help of that provider so you guys can partner on how to do this in the safest way possible and the most effective for the patient's pain control.
Yeah, so buprenorphine, I think people don't use because it's more complicated, right? Hydrocodone is like, 5 milligrams TID, it just kind of is pretty easy. Buprenorphine is a little bit more nuance. So if you're going to start someone who's opioid naive, it's a very low dose, like 1 to 2 milligrams. It's a very potent opioid, but it doesn't have that same respiratory depression. Once people get dependent on opioids, it's hard to get off. You have to really go through withdrawal. So we stabilize them on buprenorphine because you can't overdose on it and it blocks other opioids as a part of their opioid addiction treatment.
Mm-hmm.
So if you're doing a very minor procedure and somebody's on buprenorphine, just add in multimodal analgesia. They will do great. If you're worried, look on their cures, contact a prescriber. All right,
Yep,
we gotta
that's
wrap
fine.
this up. Okay, couple other things. Liposomal bupivacaine, a local anesthetic that lasts for several days. That sure seems useful. What it is it's a special preparation of bupivacaine that stays at the site where it's injected longer, up to 96 hours. And these are kind of duh statistics, right? If they have longer acting local anesthetic, they have better pain scores after procedure, they don't need opioids, and they don't need opioids. So it's a really effective way to treat pain that extends after the procedure, again, as a part of an opioid sparing regimen. The issue is it is expensive. We've got a couple local OMFF folks who use it here in our area around specific procedures. Um, just want to give you just a quick overview. It comes in a little different concentration compared to standard bupivacaine. Bupivacaine usually comes 0.25 or 0.5%. The liposomal is a little bit stronger. Because it's in those liposomes, it has to be given through a bigger needle. Otherwise, it clogs. And it apparently doesn't mix well with non-bupivacaine local anesthetics like ropivacaine or lidocaine. So you don't want to mix them, but you can mix it with standard bupivacaine and that can be given together. And then the good news is because it stays locally, you're less likely to get local anesthetic toxicity. So if you are interested in learning about this, I would reach out to a local oral surgeon who may have some experience with this. Okay, we're in the home stretch. So this is kind of what we've been talking about. Use opioids for the shortest duration at the lowest dose. Patients often need fewer opioids than we think they do. Take a look. This is from JAMA Surgery in 2017. This is in a procedural setting, right? Reb and I don't do procedures anymore. We don't inflict pain as a part of the healing process, but our surgical colleagues, dentists, oral surgeons do, right? And we don't want our patients to suffer after a surgery. For 7 different types of surgeries, up to 92% of patients had leftover opioids, and as many as 70% of tablets went unused. That's a lot of leftover medication. That could get into the hands of a teenager, or patients don't know that they're supposed to stop when the pain goes away and keep taking it. So, like I said, the data would suggest that our patients need fewer opioids than we often prescribe. I love this study. This is from our home turf in the emergency department. Patient reported opioid pill consumption after an emergency department visit. How many pills are people using? Back pain, kidney stones, fracture dislocation, musculoskeletal injury. The average prescription was for 12 pills, and 93% of patients had pills left over. For kidney stones, those hurt so much. The average person took 3.
Yep.
Really can be effective to use a small number of opiates for a short period of time. Now, people always tell me, they're like, doc, 1 script of opioids really can't hurt, right? Well, maybe not. For a person who's given a 5-day supply of opioids, 8% were still on opiates a year later, and 5% were still on opiates 3 years later.
It's a 5-day supply.
That does not say why. This is just the association. They could have had a new chronic pain diagnosis. They could have developed an opiate use disorder. They could have become dependent. But 1 script could be more than just, it's no big deal. And get this, we don't really give 20-day prescriptions of opioids anymore, but 1/3 of people with a prescription that big were still on opiates at a year, and 20% were on it at 3 years. 1 little script could for some patient be life-changing. So again, multimodal, shortest duration, lowest dose. And then if they have leftover meds, counsel them on what to do with them.
Yeah, so we put in drug bins and sharp disposals across the county. And so truly people walk in and it's basically a mailbox. You walk in, you drop your meds, you walk out. And so whenever patients from the ER were receiving opioids, we would print out for them, here's where you dispose them when they're done. My patients, when they have procedures, specifically dental procedures, will come in with their leftovers. They're like, okay, I have 10 pills left. And I'm just, okay, well, let's get rid of them, right? So it's very important to level set with that. The other thing I wanted to mention that Casey had touched on is surgical pain gets better. And so that level setting and setting it right from the get-go is you're probably going to have some of these left over. The worst part of the pain is the first 48 hours. And then after that, we expect it to start getting better. So, level set that this is going to happen and how to handle it when it does. Getting them into treatment. That's where we come into this whole thing. So if you find these red flags. If you talk to someone, if you're worried about someone, if you see anything that you're concerned about, there are places to get help. And this goes back to your local coalitions, your hospitals. These are the substance use navigators we have in every hospital in our Tri-County area. It's one of those things is acknowledge it and know where to direct someone to get services. And so truly, this is kind of number 8 on our big list of how do you make a difference? How do you start tomorrow? If someone needs help, figure out how to get it for them in your local community. We actually put together these giganto handouts, hand them out all over the place. And it's not just, oh, you have a substance use problem, but it's in addition, we have on here our suicide hotline, the YWCA, our teen crisis line. You know, there's a lot of services in the community and bringing those to people as a provider and as a leader in your community. This is really important.
Last thing, and then we'll go on to some questions because it's 7:50. People always ask us, how do we prevent drugs from getting into our community? And I remember one of my high school classmates, I ran into him maybe a couple of years ago and I hadn't seen him in a while. And he's like, hey man, have you heard about this fentanyl stuff? I bet if we bombed the people making it, it would go away. And I was like, well, ironically, I practice addiction medicine now. Maybe I can give you some insight on that. And here's the science on how we prevent drugs from arriving into a community. This was a study from, I think, the early 2000s. And it was said, and it basically said, when we look at an intervention, if we spend $1 million, how many kilos of drugs don't come into the community? So on the upper left, model prevention, that's DARE. That's like organized school activities. That's if DARE is very ineffective. Source country control. That's going to the country where the drug is grown and trying to eradicate it. That does not work. What is $700 of raw coca leaf in the mountains of Colombia, when processed, smuggled, put into baggies, and sold on the streets of New York, is worth something like $130,000. There is no other market on the planet with that level of profit. They will find new ways to get more drugs. The next one is longer sentences, typical dealers. That's changing the consequences of drug dealing. Interdiction, that's seizures at the border. Model prevention, that's DARE if it's actually working better. The next two, enforcement, sentences, those are again changing the consequences of drug dealing. Model prevention, that's if DARE really works. Federal enforcement is changing how law enforcement works together to actually try to crack down on drug dealers. Take a look at treating addiction. Do you want to give it the dramatic pause?
Oh, yeah. Stop demand.
Truly.
There's the question.
Why do people sell drugs? Because people buy it. Now, in all reality, we need all of these, right?
Yep.
We want to interdict at the border. We want to go to schools. We want to punish drug dealers. But we also can't forget that the biggest effect is for treatment. So if you're wondering why we spend our evenings as a couple talking to people about how to increase access to addiction treatment, this is why. I will tell you, I go to a lot of schools. I went to, I think, almost 30 schools in 2024, spoke to over 5,000 kids. Those kids are bright little brains waiting to blossom into adults. And if I ask those kids, what do you want to be when you grow up? I want to be a nurse. I want to be a soccer player. I want to be a race car driver. No one says addicted. No one says homeless. There's always a story. And one of the things we've learned to do with our patients with addiction is to learn that story. And it helps us to understand if it was PTSD from childhood trauma or a strong family history, that opiates feel better than for the average person. And then the best part about addiction is on Friday, I am taking 4 people in recovery. Between the 4 of them, something like 20 years of recovery. They'll walk into a room with me and no one can tell that they're in recovery, because when you're in recovery, you get your life back. And it's so cool to see the transition where people go from these deep, dark secrets of their addiction to becoming drug and alcohol counselors. And these deep, dark secrets are now their superpower to be able to help others. Sorry, I get emotional when I do this. Okay, I think we will stop there. We've got 6 minutes to do some questions. I saw some folks in the chat. Dr. Yuen, hopefully I'm saying your name correctly. I'm glad you liked the book. We can free associate. We can talk about topics. We can take questions. But I just want to say we do appreciate all of you taking the time to learn about safe prescribing and multimodal analgesia and all the stuff we talked about tonight. Q&A. First question, is the version used as hospitals as addictive as these street ones? So the first thing is a compound is a compound. So morphine is morphine, whether you get it in the hospital or in the illicit market. The difference is usually is that in the illicit market, the dose is much higher and it's also adulterated. So let's say somebody gets fentanyl in the hospital, they might get 50 micrograms. They might get, 300 micrograms on the street because the dealers got so much more of it. So some people can get addicted in the illicit market, and some people can get addicted from a medical setting and then transition to the illicit market. Is there a chance that things like pure monk fruit sweetener from China can be laced? I don't know the answer to that one. This gets really complicated when it comes to interdiction because we do not have any authority over what's made in other countries. So here in the US, we have the Food and Drug Administration, and they ensure that things that are supposed to be in it are in it, and things that are not supposed to be in it are not. Whether that's food, whether that's antibiotics, whether that's pain meds. Here in the US, the big gray market is the supplement industry. If you didn't know, the supplement industry is largely unregulated. Rev and I could literally go to get dirt in our backyard, call it a proprietary blend, and sell it as a supplement. That is absolute truth. We tend to see the supplements either not contain what's supposed to be in it or adulterated with some things, which could be like heavy metals. People will talk about getting supplements third lab tested. It doesn't actually, I mean, sure, maybe it gives you some good peace of mind, but it's hard to know if they actually, to what standard it was held. In terms of from other countries, I can only speak to really the prescription drug market. Our patients will go and buy like Norco or Tramadol from other countries. It's a crapshoot. I've had patients buy Xanax from India and it was placebo. There are some people who get medicines from Mexico which contain the medicine. Sometimes they contain fentanyl. So I have not heard of sweeteners being adulterated. Um, but I would say that things from other countries, because they have a different regulatory system, it's a little bit hard to know. The other thing that will also happen in places like Europe is that all the countries, even though they're in the EU, have different regulatory restrictions. So ketamine is restricted in one country and then not in the next country. So drug distributors will import it into, say, Germany and then drive it into France, hoping that no one notices. So it gets complicated when there are multiple countries next to each other. Here in the US, it's a little bit different.
Yeah, so the next question. Thank you so much. Is it safe to give lorazepam for pre-op anxiety for dental surgery if the patient is recovering from narcotics? That is tough. Benzos are a class of chaos in addiction medicine, something that Casey and I both do the for benzos. With that, if you feel as the provider and in chatting with that patient, and I would absolutely bring it up and put it right on the table to talk about it. I am concerned this medication, benzos, and I said class of chaos, that medication class is so hard for us in addiction medicine. Talk to them about the risks. If you genuinely feel they need one or two doses and you feel comfortable that you've talked to them about their history of addiction, how to prevent any problems with this medication, that it is not a renewable prescription. This is not long-term. This is 2 pills or however you're going to do it. It's that risk-benefit ratio. The reason benzos are so challenging for us is people love them and there is no end in sight. There's absolutely no buprenorphine for benzos. There's no treatment that is actually helpful or healing. So it's truly a conversation, and I would have that very openly and honestly. I'd love to hear your
Yeah,
thoughts.
I usually tell people that like benzos long term really are not good. Remember opiate-induced hyperalgesia where the pain sensitivity goes up? The brain's the same way with anxiety. Anxiety is a protective response to be aware of threat. So when people are on chronic benzos, the brain dials up the anxiety sensitivity because it's worried something bad could happen and they wouldn't be able to respond. Some people truly have a benzodiazepine use disorder or a benzodiazepine addiction. They snorted them, they smoked them, they stole them.
They bought them off the street.
That person probably should not get a benzo unless there's no other way to get them the procedure. It could be really triggering. It could bring up those old chemical pathways in the brain. But if someone's drug of choice wasn't a benzo, I generally view a one-time pill to facilitate medical care, fairly low risk if you talk about it with the patient. So yeah, my patients are like, Doc, I need an MRI and I'm claustrophobic. I'm like, it's okay. We'll do one dose of Valium and we'll get you through it. So, but again, we've had one of my patients passed 3 years ago. Benzos were her drug. She would go into rehab and smuggle them in and lie and steal and snort them. And just for that person, it would be just, we cannot go back there. All right, y'all. Well, it is 8 p.m. and
Nice.
we have a kid to go feed, and many of you do too. So, hope this was helpful. And Dr. Davis, I know you have 4 kids because you mentioned it while we were getting started. So you have more work to do than we do.
I do. Well, it's funny is they're all asleep now. So, but we really appreciate your lecture here today from all of us here at all of the dental societies that you've touched tonight. Thank you for your time. And then for everybody else, the your certificates are going to be emailed to you over the next week or so, and then from the dental society that you belong to. Thank you, Dr. Close. Thank you, Dr. Grover. You guys were amazing and actually very, very good lectures on a topic that sometimes can get a little bit diluted. So we really appreciate your time.
Thank you.
And you got to see how dysfunctional our marriage is. So that hopefully added to the entertainment.
Bad. It could be worse.
I
All
love it.
right,
Thank you,
y'all. Thank
guys.
you.
Have a good night.
Oh, you too. Thank you.